Thank you, Mike. Thank you very much for that kind introduction. I couldn't agree more about the music in the garden. That was, I left Bassett in 2015, and that was something I always loved in the summer here, so I was glad to see it still going on. So tonight, what we're going to talk about tonight is lifelong joint health. Musculoskeletal pain is something the majority of us will experience as we get older. I know middle age has not hit the way I was hoping it would, but we're going to talk tonight about some basics of things we can do to try to maintain our joint health, and when things are going wrong, what options we have to try to treat that. Briefly, we're going to go through four main categories of things. First off, we're just going to go over a review of what a joint is, what the components of a joint are, and then some typical age-related changes to a joint. After that, we'll talk about some common degenerative conditions that many of us will experience that lead to joint pain and dysfunction. I'm not going to go into specific traumas to joints or some rheumatologic conditions. I'd be happy to try to answer questions about any of those that you might have at the end. Then we'll talk about evidence-based treatments for joint health, both surgical and non-surgical treatments. And lastly, we'll finish up with some preventive things that we can all do to try to maintain our joint health for as long as possible. And this is why. So I hope my main point that I'd like to convey to you tonight is that joint health matters because exercise matters. It's been said that if you could take the health benefits of exercise and put that into a pill, it's the one thing we would all take because it positively affects so many different things. You see somewhat of a list here. So it affects heart and metabolic health. If you're diabetic, it helps control your blood sugar. If you have cancer, it can improve longevity. It is preventive or partially preventive for some cancers. I don't want to suggest tonight that exercise and diet and those sort of things are a panacea that will fix whatever ails you. You should still seek medical care, but they do have positive effects on our health. It affects mental health, certain psychiatric things like depression. It also affects some neurodegenerative things like Parkinson's and dementia. Specific to our talk tonight, it has a very positive impact on bone and joint health. It can affect lung and kidney function, and then it affects overall longevity. Exercise is the one thing, we all face struggles in life, and when your health is faltering, it's that much more difficult. It's one thing we can all do that will have positive benefits on our health and hopefully enable us to live more full lives. Across the board in all age groups, people who are physically active consistently report higher feelings of well-being and satisfaction. So again, this is the main point tonight, that your joints contribute to your ability to exercise, and that contributes to your well-being. So next we're going to go into joints. The type of joints we're going to be talking about tonight are our big joints that have lots of movement. Those are called synovial joints, and there are 6 components of those. You have the cartilage, which is what lines the joint, and the synovial fluid. That's the lubricating fluid that gives some nutrition to the cartilage. Those two things, the cartilage and the synovial fluid, are important for smooth motion of the joint. Then you have ligaments, which connect the bones, and tendons, which connect the muscles that move the joint to the bones. The ligaments and the tendons are important for the stability of the joint. Lastly, you have the muscles and the bones. The bones provide the main structural support, and the muscles provide the power to move the joint. So 6 things that are all important to joint health, and changes happen to all of those as we get older. This is just a diagram of a knee. Let's see if, so I do have a laser pointer here. Just to go over those components of a joint again. So on the left, you see the bones. You have your tibia, your fibula, your femur. Then you have the cartilage that lines the end of the femur there. Think of the end of a chicken leg. It should be fairly firm, nice, smooth, and white. You have ligaments. Here in the knee, you have the ACL and the PCL, your collateral ligaments on the side. The knee has menisci. Not every joint has those, but they're in the knee. And then here you have the muscles overlaid. So you can see your quadricep muscles coming down to your patella, some of your leg muscles, some of your hamstring muscles coming in. So that's the basic, again, structure of a joint with an example. As we age, natural things happen to our joints that make them less functional. For one, cartilage loses some of its water content, which makes it become thinner and more susceptible to wear. Cartilage cells are one of the longest lived cells in our body, in contrast to something like your GI tract, where some of those cells will turn over every few days. Your cartilage cells live for decades, and they don't take an injury very well. They're sort of like elephants. They have a long memory. But eventually, often, they will start to wear out, and they don't really replenish themselves very well. Our muscle mass and our strength starts to go down as we get older. That starts in our 30s. It can really accelerate after our 60s. That's called sarcopenia, and we'll talk about that in a little bit. Our bone density also peaks in our 30s and starts to go down as we get older. That's particularly an issue for women after menopause. Our ligaments and our tendons become stiffer and less able to support the joint. And then our overall ability to heal from an injury slows down. And so injuries that we recover from easily when we're younger take longer to recover from, and we maybe don't get to the same level of function that we had when we were young. It's important to note that none of this happens suddenly, and it's not a complete collapse of a joint. For each of these issues, there are things that we can do to try to improve the function and the health of our joints. Unfortunately, there is no fountain of youth, so if you came tonight hoping to hear about that, you can test your joint function and walk out now. But yeah, there are things that we can do that will make our joints better. Next, we'll go into some common degenerative sorts of conditions that affect our joint health. The first two are osteoporosis and sarcopenia. So osteoporosis is loss of bone density, which raises the risk that we'll get a fracture. Importantly, there are no symptoms to tell you you have osteoporosis. Often you don't know it until you've sustained a fracture. Often after a relatively minor trauma, you trip and you fall and you break your hip, for example. It affects women about 4 times as frequently as men over the age of 50. The prevalence of osteoporosis in women is about 20%, and it's about 4% in men. There are screening recommendations for women. The way to diagnose osteoporosis is with a screening imaging study called a DEXA scan. For women, the recommendation is that you start getting those scans after age 65, younger if you've gone through menopause and you have certain other risk factors. But it's very important here to say that it is essentially a silent disease. There aren't things you're going to feel or experience in your day-to-day life that tell you you have osteoporosis. Sarcopenia is a corollary to osteoporosis, and that's loss of muscle mass. We all lose some strength as we get older, but sarcopenia is a more advanced form of muscle loss, and that affects many things. In contrast to osteoporosis, there are symptoms that you will notice from sarcopenia that can clue you into you maybe have an issue and need to do something about it. Those would just be reduced strength. So if it's getting harder to stand up from a chair, if you feel like you're slowing down when you're walking, things like that are some symptoms. If you look at yourself in the mirror and you're not like most of us and have put on an insulation layer with age and you can see that your muscle mass is less, that's a risk, or that's a finding of sarcopenia. The good news is that for both osteoporosis and sarcopenia, they both respond to weight training and to nutrition. So there are things that you can do to alleviate and even reverse some of those symptoms or some of those findings of the disease. If you have been diagnosed with osteoporosis, there are other prescription sort of medications that your doctor might put you on to help combat that. All right, so next we'll talk about osteoarthritis and then rotator cuff disease, which are two common joint-related ailments. Osteoarthritis is often referred to as wear and tear arthritis of the joint. More than half of us will eventually experience some level of that. It most commonly affects our knees, our hips, or our hands. Not always all of those, but those are the joints that are most commonly affected. It is more common as we get older. It's not nearly the male-female difference of things like osteoporosis. Symptoms of osteoarthritis are pain, stiffness, swelling in joints. Those are all findings. Feeling just a little bit creaky as you move or hearing snap, crackle, pop from your knee as you go up and down stairs. Those are all findings of osteoporosis. Rotator cuff disease. So your rotator cuff is a group of 4 small muscles in your shoulder that are important for shoulder function. And it's another body part that as we get older, the blood supply to those tendons is not as good, and as we've used them more, there's a very high incidence of getting rotator cuff tears as we age. In fact, over age 75, it's estimated that 40% of us will have a full thickness rotator cuff tear and not know it because it's asymptomatic. So full thickness meaning one of those 4 tendons is completely torn. Now, sometimes rotator cuff disease does cause symptoms, pain and loss of shoulder motion, and we'll go over that later, but that would be a reason to seek care. There are things we can do about that.
But this is a newer diagnosis, which I think is important to go over for the women in the audience. So musculoskeletal syndrome of menopause has only been described for the last couple years. It's a clinical diagnosis, meaning there's no specific test that can be done to tell you that you have it, but it has symptoms. So parts of joints, the cartilage, the ligaments, the tendons, all have estrogen receptors. As estrogen falls with menopause, you can have symptoms related to that. New or worsening joint pain and stiffness would be one of those hallmarks. And over 50% of women, as they're going through menopause, will experience that. It used to be something that maybe would get brushed off as, oh, you're just getting older. Now we're realizing, no, it's a real thing. There's something we can do about it. So it is important to note that often, 40% of the time is estimated, there's no imaging abnormality. So your knee starts hurting, you go in to see somebody like me, we take an x-ray or get an MRI that looks essentially normal. That doesn't mean it's not something going on, but it can be treated with things like hormone replacement. Okay, so we're going to focus specifically on evidence-based treatments, meaning what do we have good scientific backing to say this is a reasonable thing to do for your joint pain and is likely to help you, and then hopefully we think we know why. I would like to spend some time on a category called orthobiologics, which it is broadly taking something from you or from somebody else, some sort of biologic material, and injecting it or implanting it somehow in the idea that it will treat a disease. So PRP, which stands for platelet-rich plasma, is one of the most well-studied of these. Platelet-rich plasma, there's a lot of nuance to it, but plasma is the component of your blood that doesn't have cells, sort of the water component. Platelets are the cells in your blood that form clot. And platelets have a bunch of different chemicals in them. And we originally thought, oh, or some of those chemicals are responsible or have effects on healing processes in our bodies. So we thought, oh, if we can concentrate these and inject them at a site of injury, it's going to reverse an injury or treat it. Sadly, there is nothing out there that we know of that you can inject and reverse arthritis once it has started, or even fully stop it. But there are things that can improve the symptoms that it causes you, and PRP is one of those. I've tried to limit these recommendations to things that are supported by the American Academy of Orthopedic Surgeons, the AAOS, and then the Biologic Association, which is a joint industry and several orthopedic subspecialty societies body, which is dedicated to scientific study of these orthobiologics so that we can figure out when do they really work and how do we make them work. So just to give you some sense of the nuance in PRP, my platelet count will be different if I do them now versus tomorrow morning. It would be different if I went and exercised before I did the draw. There's all sorts of things that go into it, so it's not as simple as just having someone draw your blood, separate out PRP from out of and inject it. And it's also very important to say that although there is good evidence now that PRP improves the symptoms of knee arthritis in particular, it is almost never covered by insurance, and it can be quite expensive. So on average, it might run you $500 to $1,500 per injection, can be even wildly more than that. And we often, for knee arthritis, for example, would do a series of 3 injections. So it can be pricey, but it does have good evidence. Stem cells, the idea behind those is we have certain cells in our body which have been called stem cells that have some ability to turn themselves into other types of cells in the body. Whereas, for example, a cartilage cell only becomes a cartilage cell. The thinking is sometimes a stem cell could become a cartilage cell. Again, the initial hope was that this would be something that we could inject. It will heal damage in joints or other musculoskeletal injuries. And we really struggled to bear that out in studies. We do use some things that can be described as some stem cells sometimes. 2 of those would be BMAC, which stands for bone marrow aspirate concentrate. Take some of your bone marrow out and concentrate some of those cells and inject it back into a site of injury. There are also fat injections where we take some fats, almost like liposuction, separate or purify the fat, so to speak, and then inject that. It has some stem cell-like activity. Again, these can improve symptoms in some degenerative musculoskeletal conditions. They are sometimes useful more as an adjunct to surgery, meaning if we do a rotator cuff repair and we inject some BMAC, maybe that improves the healing sometimes. But again, they're costly, and we still don't know really the nuance of them, of exactly how to use them to their full for benefit. There are dietary supplements that many people will take for arthritis, and some of them have good effects. You may have heard of glucosamine and chondroitin. That's been around for many years. Unfortunately, we don't have any good evidence that that is beneficial. So most orthopedic and other arthritis bodies like the American College of Rheumatology or the Osteoarthritis Research Society no longer recommend glucosamine and chondroitin. The thought with them was they are part of the matrix which your cartilage cells live in. And by taking that as a supplement, that would help sustain that matrix, but it just hasn't borne out. Collagen is another one that many people with arthritis take, and it's marketed for arthritis, but it also doesn't have strong evidence that it is beneficial. The thought with that was that collagen is an important component of many of our soft tissues, including cartilage, including ligaments, including tendons. And so taking it in supplement form, maybe that would help build those tissues back up if they're a bit worn out. But again, it doesn't worn out. There's somewhat silver lining is if you're taking collagen, you're basically taking a protein supplement, which is important anyway. So it's you get some things from it. Supplements that do have some good evidence are turmeric. That has been shown in some studies to have similar pain efficacy to some over-the-counter pain medications like Advil, and it has some anti-inflammatory effect. It is not well absorbed if you just put turmeric, the spice, on food. So you need to take an activated form. And usual doses are somewhere between 1,000 and 2,000 milligrams, often divided half, twice a day. So omega-3 fatty acids, fish oil, that has some positive effect on joint inflammation and joint pain. There's less of a consensus on what the appropriate dose of that is. They're taking 1,000 to 2,000 milligrams. Again, seems to be a reasonable amount. And then creatine, you may have heard of that. That doesn't directly affect your joints. Creatine helps your cells replenish their energy when they're working hard, but it has a very positive effect, and decades of research now supporting it in boosting strength. So it's high-intensity strength training, and strength training is very important for joint health. So creatine is something you could consider as part of a general musculoskeletal health regimen. It's very important to mention with all of these supplements that none of them are regulated by prescription medications. So it's hard to know that you're getting what you think you're getting. I've put 3 certifications here on the slide, or places you can check that at least let you know that what it says is in the bottle is what's in the bottle, and the dose that's in the bottle. It says nothing about whether the health claims that the bottle makes are true or not, but it does help you know that if I'm intending to take turmeric and I go to Costco and I buy the big bottle of turmeric, that I'm actually getting and not ground up paper towel.
I think hey, Dr. Marsh, people take all of those supplements? It's like all of them together. You can do all 3 of them together?
Yes, and yeah, you can. You should, if you're taking high doses of turmeric or omega-3s could have an effect on eating. So if in blood thinners or those sorts of things, you should discuss that with whoever is prescribing those for you. But those are fairly high doses. But yes, people take all 3 of those and a whole host of others. I've only listed these because there are some that have some good evidence that they might actually do what you're intending them to do when you take them. All right. So, what are our surgical options if we're having joint issues? I'm going to start on the right side of the slide with arthroscopic surgery, and what I would more broadly classify as joint preservation options. So that arthroscopic surgery is surgery where we put a camera in a joint, other instruments, and we treat some sort of injury within the joint, whether that's a ligament reconstruction. That particular picture shows a knee, and that's a torn meniscus that's being cleaned up. But joint preservation options are for before arthritis has set in or when it's still fairly mild. There are open surgeries, meaning bigger incisions, not arthroscopies, that are also useful parts of joint preservation. Some of that is certain types of cartilage transplants. For example, with the knee, if there's a deformity of the joint, say for example, there's someone that has variable legs, sometimes we will correct that mechanical problem by cutting and realigning the bone to shift where stress is. But there's a host of joint preservation options that can improve joint function. Those again are for before you have any significant amount of arthritis. Once you have arthritis, the results of those surgeries are often fairly disappointing. They don't substantially change the symptoms that people are having or provide durable relief. So if you have arthritis and it's become sufficiently symptomatic and you've tried all these other things and it's just having a big negative effect on your life, you do have surgical options. Currently, that option is a joint replacement. So there you see an x-ray of a knee replacement. That's when we cut out the degenerative joint surfaces and we replace it with some sort of metal and plastic or ceramic or something like that. And modern joint replacements will reliably last 15 to 20 years or more for the hip or knee. So they are a good option if arthritis, again, has become severe enough and has caused you a lot of symptoms that nothing else has adequately, if I would manage fully. Okay, so what can we do to try to prevent our joints from fully wearing out? The most important thing that you can do is strength training. So that has a very important benefit to both your bone density and your muscle development. The good thing is that although you may not respond like you did when you were 20, you could go to the gym when you're 85 and you will still see improvements in your strength. 2 or more sessions a week is the general recommendation for strength training. And it's also important to get some aerobic activity. There you want to do at least 150 minutes of exercise a week. This can be hard if you're a person who loves cardio and hates the weight room or vice versa. You need to do both, but strength is really what your joints need to protect them, to maintain your balance, all those sorts of things. People often ask, well, what kind of strength training do I need to do? And the answer is really anything you find that fatigues your muscles. You don't have to become an Olympic powerlifter. You can if you want, but there's even just low load, if you take it to muscle fatigue, is beneficial for building strength. There are newer things like blood flow restriction, which is a rehab technique where you can exercise a muscle at a very low weight compared to what you would use if you were trying to lift something heavy. It involves putting a tourniquet on it. It shouldn't be done just in the garage. You need special sensors to do it, ideally. But the benefit of that sort of training is muscle will respond almost as if you were doing that very heavy lifting. So the point is there are lots of options to try to build strength at any age, and that is very beneficial to your musculoskeletal system. I would make a couple comments about the bottom there, the consistency. And there's several groups of people where exercise is hard for. One is some of us just don't like the exercise to begin with, and that's hard to get over. The other group is people who were really into athletics when they're younger, and they start to get some of these degenerative conditions, and they can no longer do what they expect themselves to be able to do or what they enjoy to do. And they might fall into a little despair and just kind of throw up their hands. But neither of those is the best option. I would encourage you, if you're having difficulty finding exercise that you enjoy, to look for some sort of group class, because often the camaraderie of that will make it more fun and keep you going, and you will enjoy the benefits of it. How should you eat? So protein is critical to sustaining muscle, and a lot of us struggle to get enough of it. A basic recommendation would be to eat 1.2 grams per kilogram, so roughly every 2 pounds of body weight per day. You can get that from a variety of sources, so it doesn't have to be meat, but making sure you get adequate protein is really critical to sustaining your musculoskeletal system. Then calcium and vitamin D are both important for bone health. you want to get up to 1,200 milligrams of calcium from your diet. If you're not getting it from diet, you can take supplement. And then vitamin D, particularly someplace like Alaska in the winter, you're not getting it from the sun, so taking a supplement. I should mention that this is just an association, so I'm not saying that ultra-processed foods or added sugars are a direct cause of joint-related issues, but they are highly associated in many studies. So consider limiting those as those are a big part of your diet. One of the most beneficial things, in addition to resistance training, that we can all do is try to keep our body weight closer to our ideal body weight. That is extremely difficult, but it has important effects. It's been shown that losing 5% of excess body weight will show noticeable improvements in cartilage, rate of change on an MRI, wearing out lives. If you think about it, every step that we take, our lower extremity joints might see 3 to 5 times our body weight. So even if I just lose 10 pounds, that's 30 to 50 fewer pounds per step that I'm putting on my joints. It's difficult if you have joint pain and you're overweight because joint pain makes exercise difficult. There, I would try to encourage you that, again, you may perhaps, if you previously liked to run, for example, and that's no longer comfortable for you, you have many options for what to do for exercise, and I would try to find something that you can do. I don't at all mean to say that losing weight is easy. It's quite difficult. Now there are even some medication options, so if that's something that you would consider, you might want to talk to your primary care physician. But lowering your weight, if you're carrying more weight than you need, has a clear improvement in joint health. When should you see a doctor? So what I would say here is that if you're having joint problems and it turns out you have some sort of arthritis, you have more options available to you early on than you do if you wait for it to get to the proverbial bone arthritis. So if you're having joint pain, new joint pain or stiffness that's lasting more than a few weeks, that would be a reason to see somebody. Certainly if you have an injury that causes swelling or pain in a joint when you try to put weight on it, you should go get checked out. That third bullet are also related to osteoporosis, which can cause vertebral compression fractures. So if you notice I'm a lot shorter than I was, or you have sudden back pain, that sort of thing, that would be a reason to get looked at. Specific to the rotator cuff, again, it's very common, but if you are middle-aged or older and you have new shoulder pain and loss of motion, before I could do this, now it really hurts and I can only get into there, you should get that looked at. And then lastly, again, for women, there is a lot of joint pain that goes with menopause that's not just normal aging and can be treated if you are experiencing that and you talk to your physician. Now, for all of these sorts of things, it is reasonable to see your primary care physician first. I'm sure myself and any of the orthopedists in town would always welcome you coming to see us, or there are primary care sports physicians in town. But your primary care doctor is a good place to start for all of these things. All right. So what I would like to, again, try to reinforce for you is that some joint degeneration is very common as we get older, but it's not inevitable. And even if it's happening, there are things that you can do to try to minimize the amount of symptoms that it causes to you. Resistance training, weight training is the most important thing you can do for your joint health. And again, twice a week is the recommendation, the minimum recommendation for that. That third bullet, popular isn't the same as proven. There is a whole lot of hype right now about stem cells and all those sorts of things and different supplements. And to be fair, part of that is because as the medical establishment, we don't have perfect treatments for a lot of these things. And so people look elsewhere, hoping that something will help alleviate the symptoms of their allergies. But I would encourage you really to check the evidence on any treatments you are considering. People will travel overseas for certain types of stem cell injections. There are, just be careful if you're considering those sorts of things. And especially if you're putting out money, you don't want to just throw money away. And you want to get what you think you're getting. So back to those supplements, checking for some of those certifications to be certain that what you are buying is what you're actually wanting to buy. And then don't wait for symptoms to really become disabling before you get them evaluated, because you have more options to go on. Right, that was all I had. I put this website here. This is a website that's sponsored by the American Academy of Orthopedic Surgeons, and it is designed specifically for patients, and it's got a host of information about all sorts of musculoskeletal conditions, including the orthobiologics and those sorts of things. It's a good place to look at least if you want to know what does the establishment think about, and then what I'll do. So I'll take any questions if anyone has any, please. Yes, ma'am.
You were speaking, you desired single level charge jewelry or jewelry?
Yeah.
Active or activated. What is that?
So it is, if you could. Yes, the question, I'm sorry, was with turmeric, I mentioned that it needs to be activated. And what did I mean by that? So turmeric, just the spice by itself, the yellow powder, is very poorly absorbed by our GI system, so it needs to be activated. The traditional Ayurvedic way to do that is to combine it with some black pepper. But if you look at a lot of the supplements, they will say whether it's an activated preparation or I just think that if it is activated, your body is better able to absorb. Yes. Yes, sir.
You talked about the PRP injections, but I was curious about cortisone and also the gel injections that are often prescribed.
Excellent question. So the question was, I mentioned PRP. I didn't mention any of the other types of injections. So the joint injection that's been used the longest would be a corticosteroid, with some sort of cortisone, prednisone type injection. That's a potent anti-inflammatory. So I also should have mentioned that arthritis means inflammation of the joint. So you are injecting an anti-inflammatory at the site of inflammation in order to diminish it. It's very effective, but it has some long-term costs to the joint. So repeat steroid injections, eventually there seems to be a risk that the steroid will cause some things to wear out. And we don't know when it's too much. So usually most of us who do joint injections will offer people steroids in part because it is something that insurance covers, and a single injection is of low risk. But that's the corticosteroid injection is an option for a host of joint degenerative conditions. You also asked about the gel injections. That's typically something called the hyaluronic acid, which you'll note if you look at cosmetics, you'll see hyaluronic acid in all sorts of things. It's also a component of the synovial fluid, the lubricating fluid our joints make. So that's the idea there. We don't, like a lot of these, we don't fully understand what is it doing in our body that improves symptoms, but it seems to have decreased the inflammation somewhat, and it is an effective treatment for some arthritic sort of joint conditions, particularly in the knee. It's sometimes paid for by insurance, sometimes not. So that can also be an out-of-pocket expense, not as expensive typically as PRP. PRP seems to have the longest length of action, But again, it's crazy. Yeah. Yes.
I have a comment and a question.
Yes.
I couldn't believe this last year.
Yeah.
I had one shot in PLP after limping for a year
Yeah.
and walking with Jay. And a week later, I can do everything but run. And I had a little troubles walking down the hill.
Yeah.
We have good days and bad days. Question, what about nitrate?
Smell.
Have you heard about the nitro?
I'm not sure.
Novel innovations for tissue regeneration and osteoarthritis.
No matter to look that up. Do you know what are they doing?
Well, I've read it a couple of times. It's pretty technical, but let's see. Do I have it in my notes?
I can try to Google it fast.
Of it? No.
So I carry this around and might as well use it, right?
I've never seen you do that.
Okay.
In particularly, which I read my writing. I tried that, but my computer failed me. 2 injections, time release formulas. This is very interesting. They stimulate bone and cartilage regeneration in 5 years out. Then the clinical trials for people disqualified or next.
Yeah, I'm sure I'm not familiar with it, but there are I do know that there are several medications or injection options that are undergoing clinical trials now that would be disease modifying and actually able to stop arthritis or potentially reverse it a little bit. As of now, none of that is on the market, but hopefully, and that's obviously the goal that we would have something like that.
They're doing it in animals. They're coming up with the human trials. I did not get into it.
Sure.
It's, I'm probably gonna. What are my odds? It's 5 years out. I don't have 5 years.
Yeah.
I want to do it now. But it's nanotechnology, I believe. And the problem is after they give you this injection, they can go other places. Like to go in your brain. And it's kind of risky.
Yeah, that's why it was really bad. It's very important that we rigorously study all these sorts of things. We haven't done that with a lot of the biologics, in part because I could go set up shop in some strip mall, put my ad for come to me and I'll make your joint pain better, and I'm going to inject this, and here's the deal for $5,000. And so I don't have much incentive then to find out that maybe my cash gen doesn't work as well as I thought. Not to say that everybody who does those is doing that by any means, but we haven't rigorously studied a lot of those to know how does it work and when the thing is. It is, I mentioned, my platelet number for PRP, it could be different now or tomorrow. And we have learned that the number of platelets that you deliver in a PRP injection is really important. There's a whole host of different PRP processing machines, and they don't all concentrate platelets as well. So we don't always know that if I get PRP today and I go somewhere else and I get it tomorrow, did I get the same thing? And if it didn't work tomorrow, is it because why? But yeah, to all these, we just need to study them to know when they work. Are there other systemic effects that they'll have?
Only as good as your own does.
Yeah.
And they had me drink, I fucked so much water. I sloshed when I walked busy.
Yeah. Yeah.
Only costing $400.
That's good.
That was a good deal. And I went to get a second shot. Because, I don't have trouble walking down the hill, and I like to hike.
Mm-hmm.
He wanted to try that. I can't say that hike.
Hyaluronic acid?
Yes,
Yeah. Is it?
He thought that would help. But I'm like, I got kicked by a horse. Like, I've done everything wrong my entire life. But this thing still, I'm different around.
That's, yeah. I think the answer is never to just sit on the couch. it can mistake.
This is so much great. I don't, as, you know, I want to, I used to learn, I used to swim, I used to ride motorcycles, I used to lift hay bales.
I should have put your picture up for this. Sir, so this, it's kind of related. There's a total knee replacement area arthritis that's associated with that knee. Does it cure that? So
Essentially, yeah. So, I'm sorry. The question was, does the total knee replacement cure the arthritis? I would say yes, in the sense that you have cut out the arthritic joint surfaces. They're no longer there. Sometimes people will still have some swelling and some of that sort of thing, but the arthritic joint surfaces are gone once you have a joint replacement. Yes, sir.
You have a DEXA scan, they might, well, set your base with the first DEXA scan. And then the second one, they decide whether you actually have osteopenia or, the first one might say osteopenia, the second one say you now have osteoporosis. Yeah, well, if it's osteoporosis that is diagnosed, does it spread? Does it go like from your hip to your back to, or is it just going to be confined to your hip? Was it?
No, so the question was if you're diagnosed with osteopenia and you're later diagnosed with osteoporosis, osteopenia just being you have lower bone density, but these are all compared to a young, healthy person. Your DEXA number versus theirs, and it's a specific cutoff. So negative 2.5 would qualify as osteoporosis. So that's how maybe can get your bone density can get worse as you age. But that's the distinction. They're measuring you against a young healthy person when they give you an osteopenia and an osteoporosis diagnosis. It can affect all of your bodies. Ones we typically think of are hips with hip, at least in the orthopedic world, in terms of fractures that we treat, hip fractures, wrist fractures. We often refer to them as fragility fractures. So really any fracture that's sustained from a pretty low energy mechanism. If I just, trip here, fall, rush and break my head, did that answer the question?
I guess it was whether does it spread you have in your hip, and then next if you have it in your back, it's not spreading, it's just as your bones all over are deteriorating.
Yes, yeah, and they're not, with the DEXA, they're not looking, let me not say that. I don't remember exactly, but the DEXA, how much of your body they scan.
From the chest down, your neck down to toes.
So the bone, we think, or the reason resistance training is helpful is we think of bone just like, that piece of wood that's supporting us. It's a living tissue and it responds to the stress you put on it or remodel. And it can make itself stronger and improve that you can overdo it and you get a stress fracture. But it's not some inner material in our body as it does respond to training.
Another question? Just curious. I'm not quite sure if I can put this well, but I've heard a couple of PTs out of the University of Wisconsin say that often rotator cuff surgeries that have been recommended could actually be treated from PT instead. I'm wondering what your thought is on that.
Yeah, I think it's reasonable to try physical therapy for the reason that I mentioned, and that being that a very high number of us develop full thickness rotator cuff tears as we get older. We don't even know it. So some of them clearly can be asymptomatic. And if that's the goal, is just to have a non-painful shoulder, it's reasonable to try physical therapy. We often will recommend surgery if somebody comes in with shoulder pain and we know that they have a complete rotator cuff tear, because we also know that the longer you leave a complete tear,
there's some additional degenerative changes that can happen to that muscle and tendon. If you eventually decide to do surgery, it may be less successful. That's another challenging thing with rotator cuff surgeries is that we don't really know what's the true healing potential of that. The fair number don't heal even with surgery, which is disappointing. But yeah, that's a long-winded answer to say I think trying physical therapy, if you know you have a rotator cuff tear, is a reasonable thing to do at least for a couple months and see if it helps.
I had a full cut that tear.
Yeah.
And tremendous success through surgery.
Yeah.
With the AT follow-up. Like,
Yeah.
it's pretty big.
Yeah, I would say all of the surgical options we have is an important component for the most successful outcomes that you do. Yeah. Yes, Sam.
But what's the coding thing for the PRP? Is it just a couple in your life or a few months or what?
Yeah. We don't know that there's a ceiling to the number of times you can do it in the question. Well, I'm hate that for ignorance. What's the protocol for PRP? Can you keep doing it year after year after year, or is there a limit? And the answer is we don't think there's a limit. The protocols vary. Specific to knee arthritis, commonly you would do 3 injections, often 1 a week or a few weeks. But there is none of that is set in stone. Yeah. Yes, ma'am.
When it comes to getting enough calcium, so I've heard that it's better to take it in with your diet instead of taking like the tablets because you're taking the calcium mainly through a tablet form. You're going to get more calcium deposits in your arteries. Is that
I would have to research that before I can give you a doctor. The question was, if you're taking calcium supplementation, are you going to get, is that worse than from your getting your calcium through your diet? With the supplements, are you getting calcium deposited in your arteries? Is that the question? That's not a risk I'm aware of. You else? Yes, sir.
Yeah, everybody probably knows this is going to be up in a couple, 3 weeks on the internet, so you can watch it again and get the transcript. Also, the university has in the gym, if you're over 65, like all of us are 60 or something like that, you don't pay tuition for a class if there's room in the class, and but you do pay like something. And I've been doing it the last 15 years. This year I'm taking the model. That's kind of a different story. Dr. Brad was in here a couple of weeks ago, and I understood, thank you for speaking so clearly. Smart guy, thinks cardiologist, couldn't understand. I don't think a third-year biology student could understand a lot of things he said. However, at the end of it, it was a clincher. He said he almost daily has this great conversation with open evidence. And you probably use that? It's an AI. And I just went to have my wellness physical and asked the nurse to use up the evidence and asked all the time. And we can't get to it, but recently I had some problems, went back to the doctor who did the surgery, and his secretary just said, Tyler probably go to emergency. Well, it didn't help, but I use not that, but there are a lot of AIs that actually took pretty darn good. The hospital just redid their patient portal, and then I haven't been able to use it yet, but they're putting telemedicine on that, and I don't think it's cost you anything. But find out about this, and maybe we can find out about out of access. You got to be a doctor to get into medical or something like that, open evidence. But frankly, our research, yeah, there's a lot of evidence on there. Yeah, I trust my doctor more, but when I can see it.
Yeah, I has heard of open evidence. So the question was about open evidence, which is an AI-based tool. I've heard about it. I don't use it regularly. I have used other AI to help with research of certain things like this clot or that sort of thing. I think it is a useful resource you could all use to get an idea of what sort of options do you have for whatever condition you're concerned about, and then you could use it to prepare questions before your appointments. We don't always takes. You may find your doctor a little what's the word? Well, anyway, it's a good way to learn for yourself and to let you know about evidence. Yes, sir.
Deb, I might have missed this, but regarding weight training, do you recommend like lots of repetitions, or do you recommend doing heavier weights? And or does it make a difference?
The question was with weight training, does the number of repetitions matter? And the short answer is it doesn't seem to when you're just talking about general joint health. What matters for strength is that you are fatiguing a muscle. So you can do that with a lower weight and higher repetitions, or you can do it with a higher weight and lower repetitions. If you're specifically a strength athlete, you're probably doing more of the high weight, low repetition. But if you're just looking for joint health and general physical fitness, it doesn't really matter. Yes, sir.
One more thing. You mentioned that, so the muscle usage. So does something like resistance training where you pull against your own body or your own muscles, will that have the same effect? Or does it need to be weights?
No. The question was, do you have to use weights if you're trying to train your muscles? And the answer is no. There are, I would say for general musculoskeletal health, whatever form of strength training you find, whether that's stretching bands or, just an isometrical sitting against the wall as if you had a chair without a chair sort of thing, whatever you find that doesn't cause you pain while you're doing it and you enjoy doing it and will continue to do is adequate. Yes, sir.
So how is range of motion related to joint health?
As joint health declines, often range of motion. The question is, how does range of motion relate to joint health? I would say, well, as joint health declines, as you get arthritic, often the joint becomes more stiff. You lose range of motion. There are anatomic differences amongst all of us. So we have not shown that you need to be a yogi in order to have optimal joint health. If you're not, some people are more flexible than others. If you're flexible to begin with, great. If you're not, you can hurt yourself trying to force a similar level of flexibility so that it's not, range of motion, improving range of motion beyond your norm is not necessarily beneficial to joint health.
Anything else?
Yes, sir.
Where's your practice located?
So I'm a FHP employee, and we're the orthopedic clinic that's in the new little building.
If they had to do another knee replacement on the replacement,
Yes.
they can. A friend of mine had her knees replaced. They were knee 60, and she's now 75. She was wondering how they have her. How do you know?
Often you will start to have some pain again or some swelling or that sort of thing, and then an X-ray might show somewhere.
And they go in and hit you and run out.
Yeah, so we used to push people harder to wait till they were older to do a joint replacement. We kind of backed away from that because the question was, can you do a joint replacement after you've already had a joint replacement? But the answer is yes, that's done very commonly. The average person now lives till they're close to 80. You see, if you might commonly get 15 to 20 years out of a knee or hip replacement. There's a lot of people with pretty bad arthritis who are 45. We don't force them to wait until they're 60 to do the surgery. So it is not an uncommon thing nowadays, and it's not something that we just do routinely. Oh, it's been 20 years, but you're doing great. We're gonna decide changing the oil, but you would have symptoms, and a second replacement is often done. Yes, sir.
Is there a topical thing that you can put on joints, PCBs or something like that, that is helpful?
There are many topicals. So the question was, is there a topical treatment you can put on a joint that is helpful? And the answer is there are many of them that are helpful to pain. There's no topical thing. There's no brace. There's no pain. There's no whatever that you can do that will reverse damage inside the joint. But many of those creams, either things like BioFreeze or ICI, Tiger Balm, take a pick. There's 500 of them. They all can provide some pain relief, hot or cold therapy. There are sometimes we kill little nerves around the joint to just kind of deaden it. There are many. I didn't go into any of that. There's a lot of pain management sort of treatments that can be done to try to decrease pain. That's from arthritic joint. Anything else?
You can get surgery.
So I don't actually do the joint replacements. I mostly do the arthroscopic surgeries, and mostly knees and shoulders. I have a couple partners who do joint replacements. There are other surgeons here in town who do joint replacements, but I don't know. Yeah.
But maybe two more questions out of respect for people's time.
Is there a difference between, like, you talked about resistance bands, and then is using resistant bands the same thing as strength training bone density? Or no, it's not any more weight than just resistance. Does that make sense?
It does. So the question was, does the type of resistance have an effect on bone density? It doesn't seem to, no. Any weight, any resistance causes force across the joint, which will have an effect on bone density. Thank you all for